Good afternoon. Good afternoon to all our watchers, viewers, and everybody out there. It's just so wonderful to have you with us today, and welcome. I'm National Director Sharlene Cassel of Epilepsy South Africa, the only national organisation that focuses primarily on persons with epilepsy. It is with great pleasure today that I welcome 4 guests as our panelists to share their expertise with all of us, and I'd like to just introduce you to each of them. First, to my far right is Sibongile Tshabalala. She is National Chairlady of TAC and also a person living with HIV. So welcome and thank you for joining us today.
Thank you for having me.
To my close left is Professor Mochan. He is Head of Neurology at Wits, and it's just such a pleasure to have you. Thank you so much.
Thanks for having me.
To my far left, it is Rue Shiri. And Rue Shiri, just wonderful to have you as well. Rue has a background in public health and is herself a person living with epilepsy. To my left is Dr. Vuyokazi Bandezi. She is passionate about wellness and has spent many years, she's a clinician, is above that as well, and she's a wellness advocate. So just so wonderful to have each and every one of you, and thank you for putting this time aside. So I suppose the first port of call and where we need to start is in conversation is to contextualize and put Andre on the spot here. Can you just share with us what is epilepsy? How is it classified? What are the types of seizures that we can just be talking to people with epilepsy out there and all their loved ones and let them know that there's hope and that there's really, this is what it is?
Big question. Give an hour's lecture now. Started. Well, but to put it in a nutshell, it's important to understand when we talk about epilepsy, obviously what is epilepsy. And epilepsy is really it's a condition where a person has repeated seizures or attacks of seizures. So a seizure alone doesn't make epilepsy, but a person who has repeated, so we speak about repeated unprovoked seizures, right? Mm-hmm. That is a condition of epilepsy. Seizures can take different shapes and forms and sizes and magnitudes. So it's a whole variety of events, but they basically originate in the brain. So it's a brain abnormality, but it's a fascinating thing in that it's a transient thing. So it happens in attacks of seizures, right? Between the seizures, that person is otherwise functioning normally. Mm-hmm. And the abnormality in the event of a seizure is basically what we would describe or call as an abnormal discharge of nerve cells, an electrical abnormality that then manifests with varying ways in a person. So that can manifest with a abnormal movement or shaking of the body. It can manifest with abnormal feelings or sensations or smells or sounds and strange things happening to a person. It can even manifest with awkward behaviors or behavioral abnormalities, or the whole range or spectrum of seizures that are possible. And ultimately, they really reflect which part of the brain is involved in that abnormal electrical activity, right? Yeah. That produces the seizure that will then manifest. So the big principles when we're looking at, you asked me about, I think part of your question was classification, wasn't it? Yeah. So classifying epilepsy, so we look at exactly where does it come from or how does it originate in the brain. So if it is a small part of the brain or one part of the brain, we call it a focal seizure that is originating from an epileptic focus. Sometimes the seizure can be of a more global variety, and then we call that a generalized onset epilepsy. And then there are others where we're not sure what it is. We call them uncertain or unclassified, but those are the big divides really. Focal seizures, the classic form would be just a hand jerking for a while and then might go to the leg or involve the face on one side, the person being awake and alert during that, and then it stops after a while. Such focal seizures, they can be either with a normal awareness or with a person being fully awake or with it, or they can be with impaired awareness, whereby the person awareness is basically clouded or up to being unconscious ultimately. Okay. That is when we talk about focal seizures. I'm still busy with my lecture, you see. Generalized seizures, yeah. So generalized seizures, they manifest from the outset with an impairment of awareness or loss of consciousness or abnormal consciousness. So that is basically how we would classify seizures. And a person can have different types of seizures. Not that one person just has one type. It can vary, and they can have go on from a focal initial onset to a generalized type seizure. So there's a whole variety. The big one that people know and the dramatic manifestation is what we call a generalized tonic-clonic epileptic seizure. So that is where the person falls down. Sometimes they have a premonition that they know that is about to happen. Sometimes it comes out of nowhere. Person falls down and has then clenches themselves into a stiff state and then goes on to have like what we would call a convulsion, for example, right? Then typically lasts seconds to a minute, or typically a few minutes maximum, and then that jerking or convulsion abates and the person is basically then asleep for a while. So that is what we classically understand as a generalized seizure. But like I said, there are many other types and shapes and forms and sizes of seizures, basically.
Okay.
What else did you ask me?
No, I think that's absolutely fine. I know how difficult it is to go, okay, this is in a short space of time what epilepsy is. We live in a world where we discuss epilepsy, and certainly as a person living with epilepsy myself, is just so much to it, right? And this today, we've got a subject that is such a deep, such a interesting topic to be discussing, and it's fascinating to be hearing these conversations for me. So I'd like to ask you, we're going to jump from the epilepsy and the side from Andre with epilepsy, and I'm going to ask you, really talk to us as a medical practitioner, as a person that's passionate about wellness. Talk to us about HIV, and in the South African context, why is it important? What is this so relevant now, how more so than ever? So if I just hand to you to give us some of your insights and your wisdom.
Okay. So I'll start from like a basic background for somebody who might have forgotten what HIV is. HIV is a human immunodeficiency virus. It is an infection, being infected by a virus. In terms of getting the virus, it will be those fluids where the virus can be in it. Typically, it will be blood and other fluids. I don't know what is the age restriction in our webinar. So in terms of the South African context, and I would say from an epidemiological point of view, when I say epidemiology is what is the problem, what is the disease in this case, who is affected, how is that particular disease spread, and what are the outcomes or the impact. So in the South African context, I would say if we look at the burden of the disease, in South Africa, we still have the highest number of individuals living with HIV. We have got about 7.5 to 8 million individuals living with HIV. So what does that say as a country from a public health perspective? It means we have a high burden in terms of managing the disease itself. Therefore, we need more resources still, even in 2022, to address HIV as a pandemic, in the country, even globally. Also, in terms of the context in the South African context, there's many much more. We also look at why are we still having HIV in 2022. So we look at what are the drivers, underlying causes, what are the risk factors. So in addressing HIV within the South African context, it's quite important to look at those structural drivers, for example, economic drivers, and the risk factors, one of them being sexually transmitted infections, meaning now we're looking at sexually transmitted infections globally. Also, in terms of the South African context, at individual or household level, who is most affected by HIV? That is the young age group. I'd say the most affected is the 15, to 45. We can break it even further. Yeah. But if you look at that age group, that is the economically active age group, meaning that at individual and household level, if HIV is not managed, therefore we might have economical effects of that household not having an income, or even individual. also from an economic public health approach, if we have got more individuals who are at the productive age group, now we have got high absenteeism and so on. So it means that from an economic point of view, you need to retrain. You have a number of people with absenteeism who are away from work. Also, what are the outcomes if HIV is left untreated? So even in 2022, the list can go on and go on. Also, we've got the reproductive age group, group. So if not managed properly, it means now we have also another risk of mother-to-child transmission. So I think I'll stop there for now in terms of why is it important that even in 2022, we are as aggressive, if I can use that term for lack of a better word, in terms of managing HIV, so that when we say by 20, in terms of the National Development Plan, when we say we want a country that is free, in terms of the outcomes of HIV, we need to be all gearing towards that.
I think once again, I listen to you and my head starts going in so many directions, because epilepsy is classified as an invisible disability. And until I started speaking about my epilepsy 8 years ago only, and I've had epilepsy since I was 8, I never knew it was a disability. I never knew. And with as a person living with HIV, it must be such a similar, I can't identify, but I can identify with living with epilepsy as that disability. And both are such large agendas, because our big theme for next year around National Epilepsy Week and International is Stamp Out Stigma. So there's such a commonality between these two, and that's why we're sitting here today, right? To say, put this on the agenda. We're all advocating. We're advocating that these things need to be discussed. And we've got professionals sitting here. We've got people living with the illness and neurological disorder. So I think that brings me to the next point, and I have no doubt that we're all going to be asking questions, because I've got a million to fire at both of these individuals already. You talk about 7.5 million, and I go, wow. We talk about 50 million people with epilepsy globally, and it's kind of, you talk about astounding numbers. These conversations are absolutely critical. I'm going to ask you, Sibongile. You've been speaking out about being a person with HIV since 2020, I think you said. 2010, sorry, humble apologies. And you're known, you're renowned, you're national chair lady of TAC. Share with us your story. We would love to hear your story. I think it would just benefit all of us and teach all of us.
Thank you, Sharlene. I was diagnosed with HIV in the year 2000. And when I was diagnosed with HIV, I was sick. I was bedridden. I stayed a month in Edinburgh, Christian Hospital. At that time, when I was admitted, I had deeper jaundice. So the doctor, when he admitted me, said, we need to do an operation to you, because it means your liver, it has problems. So we need to clean your liver and all those things. So I didn't understand what is really happening and why, as an older person having jaundice, because in my understanding, jaundice only affects children who are newborn and all those things. Until when I was in hospital, and I was asked several questions to say, are you drinking? Have you been outside of the country? What really happened? And I was not drinking that much, I only drink sometimes when we are in a party, that time I was not even a traveler. I was just a South African who's coming from Vosloorus. And I was like, how can these people ask me these questions? But they kept on testing me and trying to understand before they ran an operation. And then they tested me for HIV. Because I was very young, the doctors were skeptical to tell me about my HIV status. But eventually, because I think activism in me was still there, keep on asking to say, you cannot take my bloods and not give me results. Please give me my results. Tell me what's wrong. And the other day, doctor said, no, I think you need to know. And she told me that I'm HIV positive. And that's when my journey started. But what kept me going, honestly, it's the support from the family. Because the first person that I disclosed my status to, it was my mom. And the way she responded to me, it gave me hope. It gave me a strength to fight, because she just said, okay. I was like, hi, Bosisi. Do you understand what I'm saying? I mean, I have AIDS and I'm going to die. There is no treatment for AIDS. And she said, no, don't worry. You are my baby. I will take care of you. If you are dying, you will die for me. I will do whatever I can do as a parent to take care of you. I took care of you at birth till you were older. I'm continuing to do that. So don't worry about any other things. Just know that I'm here for you. So, that support gave me courage. So even when I was discharged from hospital, remember that time people were dying a lot of HIV. You will hear stories, people talking to say, she's HIV positive. But they don't come and ask you to say, actually, what is wrong? And I remember the other day my father had a van. So we were sitting at the back of a van with my other aunt. And she asked me to say, why your AIDS is not killing you while others are dying? And I was like, no, because I take charge of my AIDS. And I'm in control of this HIV. So that gave me strength, even whatever happens in my life. But it was from being diagnosed with HIV till 2006, when I started taking ARVs, it was a hard journey for me because I had to deal with TB, I had to deal with shingles, I had to deal with several pneumonia, bronchitis pneumonia. Now and again, I've been admitted in a hospital. In a year, I will know that at least twice or thrice a year, I need to be admitted because of several opportunistic infections of HIV. And that's when my journey started. I started taking ARVs in 2006. Okay, before I get there, I got married in 2003 to my high school sweetheart, and we were both HIV positive. Unfortunately, he died 2005 of HIV-related illnesses. And 2006, I started my ARVs. It was not easy because when I started my ARVs, my CD4 count was 164. It wasn't that bad, but it means my immune system was compromised now. Yeah. So when I started ARVs, a week starting ARVs, I started to develop side effects. One of the side effects, actually, it was a minor stroke, which my tongue could I felt like my tongue is going down. I couldn't speak properly. I couldn't move my left side properly. And I was admitted again to the hospital. And when I was admitted at Bara, I had to be taken to a hospice. So I was in a hospice for 2 weeks. But because of my positive mentality and my belief, I think that's why I survived. I remember when I was admitted in a hospice, I was put in a ward where people were very, very sick. And you could see people were dying during the night, and others are crying, others are messing themselves. And in my mind, I was like, no, I'm not supposed to be here. I'm not that sick. So they need to take me away from this room and from this ward. In the morning, the first thing when the sister came, I said, you know what? These people are going to kill me because they are dying, and I'm not here to die. I'm here to survive. And she said, no, you can talk to the doctor because she's the only one who can say we can move you to another doctor. When the doctor came, I told the doctor to say, no, I can't be sleeping in this environment. This environment for me, it's traumatizing. I'm here to live. I'm not here to die. So I want you to assist me so that I can be able to go out of this hospital. So please, this place is traumatizing me. Yeah. And she said, you know what, your positive mentality, it will keep you going. And then I was taken to another ward where people were feeling better, and I started to communicate with people, people living with HIV, and it was nice. I could see that, okay, there are people living with HIV here, and we can make it. So that's when I started eating my ARVs and continuing. So I started to join activism in 2009 because I was very anxious about HIV. I wanted to know more about HIV. So every time, because from 2006 till 2009, I was taking my treatment at Bara. So I was transferred to the local clinic. So when I went to the local clinic first, I saw this lady talking about HIV, side effects, and all this. She has a lot of information information, and I started to ask questions. And she said to me, you know what, you are asking too much and we don't have time for you now. So for you to understand all these things, we have Treatment Action Campaign. This is a group of people living with HIV. You can join. You will have treatment literacy sessions. You will know more about HIV. That's where my activist journey comes from. So that is Sibongile in short.
And I think that's like, woo! I think all of us are going, again, so many comments there. I mean, for 15 years you've been speaking about your status, and that just takes my breath away, because I only started telling people openly I had epilepsy 8 years ago. So it's a hard thing. It's a hard thing because you know you're different, you're living differently, and it's the thing that really struck me about what you were saying was the support and the response of your mom immediately. And I think it's that love and that hope, and that's one of the reasons that we run these beautiful webinars alongside Sanofi as a partner of Epilepsy South Africa with us, is because sharing information, sharing education, sharing hope is so important, that everybody living out there with these two conditions knows how robust we're chatting. I'm going to jump to Rue, and Rue's also got a fascinating story that I learned today. Some of it I learned today, and a really recent conversation for you. So, Rue, yeah, and I hope each of you are holding on to questions for each other, because once we've heard from Rue, we're going to jump in. Rue, share with us. Tell us your background. Tell us who you are. You're passionate about public health. You're passionate about epilepsy. Tell us.
Okay, so I was actually diagnosed quite late in my life. I got an epilepsy diagnosis about 2 years ago. So it's relatively recent, as I'm in my early 30s, you know. With that diagnosis came the explanation of a lot of things in my life, you know. My neurologist suggests that my epilepsy has been present my entire life. And I think it's important for me to share with you what my epilepsy looked like, because a lot of the time people assume epilepsies with grand mal seizures. That was not the case with me. You know, as a 7-year-old, it started with crippling anxiety. You know, self-harm was a part of my road, whereby it was almost debilitating. You know, I couldn't share what was wrong. Do you know what I mean? My mental health was compromised as a result of my epilepsy. Further on down the line, you mentioned funny feelings, funny smells, funny tastes. I battled with an eating disorder as well as part of my epilepsy journey. So epilepsy has many faces, and for me it was slightly different. My journey progressed. I am a person in recovery, so addiction was a part of my journey, you know, and epilepsy contributed to it. You know, epilepsy is an invisible disability, and for me, you know, it took me a long time to get on the right path to get the right diagnosis, you know. Coming into recovery was the first step, which was just under 5 years ago. And the next step was actually starting with a psychiatrist, getting a referral to a neurologist, whereby I have an accurate diagnosis. You know, with my journey off the addiction aspect, I was quite anti-medication. You know, I was so fearful of it. And I did not know the life I would have today by getting the right medication. You know, my life is completely different. I don't suffer with the crippling anxiety, the funny smells, the funny sounds, the ability to sleep at night. All of these have contributed to better quality of life, you know. So for me, my epilepsy diagnosis was a game changer. You know, I've managed to do quite well in my life. A lot of the time people question, well, my neurologist questioned, he told me, he's like, how have you managed so long? You know, with my, just my EC, not ECG's the heart. EEG? EEG. Yeah. You know, we were able to pick up, I had over a period of 18 hours, I had anything between 120 to 150 seizures. So it was completely life, affecting. And now I sleep, I wake up, I'm not affected by funny smells and foods, and getting an epilepsy diagnosis and being put on the right medication has literally been life-changing. So I think that's me in a nutshell.
Just picking up one thing you said, and I'm sure it's true for everybody around here, is that when you have a condition you're living with, that innate rebel of I'm different, so these drugs I don't want to take. You start the self-sabotage. You start the I'm feeling fine, so I'm not going to take them today. And the reality is, it's when you're feeling fine, you need to be acknowledging that, and you need to be going, I'm feeling fine because of this. And find different ways to rebel. Whether it's dancing madly, where you're cooking in the kitchen, or you listening to music, or you bouncing and putting your feet on the grass at night. It's to then self-nurture. And all of it is talking to how do we create a quality of life. And I look at so many of our residents at Epilepsy South Africa, and everything about Epilepsy South Africa is focusing on, let's talk about creating quality of lives for people in South Africa in a landscape that people are battling with quality of lives. So I want to come back to Andre. You said I could call you by your first name. So just talk to me from a medical perspective. Why is HIV an important comorbidity for people living with epilepsy?
Yeah, so that can have different sort of mechanisms to it, basically. Epilepsy itself, you've mentioned some figures, so and so. How many million in the world? You said you know those figures better than me. But it basically affects like almost 1% to almost, some estimates up to 2% of the population. So 2 out of 100, or let's say 1 out of 100, that makes more than 500,000 South Africans have epilepsy, for example, whether diagnosed or undiagnosed. So epilepsy is a common condition, so it's not a closet disease that is one can hide away or forget about. It's a very common condition. And so is HIV. So they can occur completely independently from each other in the same person, like a person with diabetes can have hypertension, right? So they can occur like this together. And the one can come first, the other one can come later, or the other way around. That's completely, that can happen either way. But there are a number of issues in which way the brain does get affected by HIV, especially untreated HIV. And that can then lead to a manifestation of seizures or epilepsy, for example. So we know from that experience that a person who is living with HIV has a higher risk of developing seizures. So in that way, they do interact in a way, and that can have various ways or forms. You spoke about the liver, for example. So when your liver fails, all those toxic metabolites go around the body, and that can lead to seizures indirectly, for example. So that is not a primary brain abnormality, but the abnormality of an organ function that can then manifest as seizures. So in that way, a person with HIV can develop seizures. But the other big issue is really, and especially when it comes to untreated or undertreated or poorly treated or non-compliant treated HIV, that can give rise to all those opportunistic diseases you've mentioned. That can be infections that affect the brain, like meningitis, encephalitis. TB can affect the brain. You can have lesions in the brain from various types of infections or from various type of kind of tumors almost that you are at risk for with untreated HIV. So in that way, there's a strong relationship, and the better the HIV is controlled, the lower that risk is. There is a bit of a scientific debate about whether HIV itself, interestingly, can predispose to seizures, and the answer is probably there is a subtle predisposition. That's the virus without opportunistic disease or opportunistic tumors or things like that might predispose that person to slightly higher risk for epilepsy or seizures. So in that way, there is a strong interaction between the two conditions. It's a wonderful platform to be here sitting and discussing that, because obviously both conditions are exactly like you all have experienced and say they are rather forgotten or swept under the carpet, and people who have it rather being made to keep quiet or stigmatized and all those kind of things. So it's an important debate to have, really.
Sabina, I think you're chomping over there to jump in.
Prof is talking. I'm relating to some of the things that are happening, and now I start to wonder to say maybe I should go and check for epilepsy, because just last night when I went to sleep, I started shaking. My hand started shaking, and I was like, oh no, what is happening? And I decided to say, no, let me rest. While I'm trying to rest, my body was shaking, but mostly my head, it was shaking like this. I couldn't stop it. And when I was trying to relax, I could feel my body jumping up and down, like there's something that is happening in my body. So I'm just wondering that maybe I'm sitting here, I have epilepsy, and what Prof can advise, I should get checked quickly so that if there is something, I can be able to be identified earlier, because I'm not that kind of a person who likes to take risks, especially with life. And I woke up worried this morning to say, what's happening? Because it's the first time hearing about this. And when I'm hearing from Rue, that funny feeling I do have. Earlier this year, I was diagnosed with severe depression, and I'm on antidepressant. So as she talking, I'm starting to relate to say, it's mostly related to what I'm feeling, because sometimes I do have that feeling to say, I don't want anything. I just want to be alone. I don't, even appetite. I don't eat a lot. Every time my mom calls me, have you eaten? Because I don't usually get hungry. I hardly sleep at night. Sometimes I will feel like I want to sleep, but as soon as I'm jumping to bed, I have that anxiety to sleep. I feel like, okay, I can't sleep. And even if my mind is tired, I want to sleep, but there's this something that says you won't sleep, you can't sleep, don't sleep.
I think what's astounding me in Andre's response in his discussion is that predisposition to epilepsy. I kind of gone and now listening to you, it's bringing about more of a consciousness, right? Of have a look at this. I'm blessed. I have auras. That's what we talk about them. Auras. I will feel funny things across my arms before a seizure. I'll have funny metallic tastes in my mouth. And I used to think that was really strange, and I'm blessed that those developed only 8 years ago because my epilepsy started when I was 8. So I always said it's a blessing. It sounds quite funny, but it saved my life multiple times now. So it's you've caught me a bit. I don't know about you. I mean, and listening to you last night, I think when you live with a condition like this, it's placing health first above all. And we know sleep deprivation jeopardizes our health.
100%.
It is, you need quality sleep. 100%. One of the things I wanted to revisit you on, and I'm going to ask you to jump in from a medical perspective, is your husband passed away many years ago. And we started talking, you mentioned you got married post being diagnosed with HIV. And I wanted to jump in with you and just talk to us a bit about contraception and HIV. And we had this discussion in 2020 on our first webinar that we did with epilepsy and contraception and in women. So it would be quite interesting to hear what this looks like. And it seems that's a topic that's going to come up again.
In terms of contraception and HIV, I would like to take a few steps back. Ideally, every pregnancy should be planned. And in planning the pregnancy, the couple must plan the pregnancy, meaning that it's true to the woman and the male partner. So before the pregnancy, what we would like to do, we would like to optimize the health in this. I'll be more specific now on the woman. So you would like to optimize the health of the woman. So now we're talking about HIV today. So what we would like to know is the HIV status of the woman before pregnancy. If the woman is living with HIV, would like to put the woman on treatment. But you said I must focus on contraception. Then if the woman,
whatever's working,
integrate.
you know, there's a lot of things. Yeah, there's a lot of things happening here. So,
yes. So like that woman who is living with HIV would like to put that woman on treatment very early on, preferably even before pregnancy, so that we can suppress the viral load, and that reduces the risk of transmitting HIV to the unborn child, or even after breastfeeding. Then the woman who is negative would really like that woman not to have unplanned pregnancy or not to be infected during pregnancy, because if she happens to be infected during pregnancy, there is a high viral load. The higher the viral load, the higher the risk of transmitting to the child. So now, in terms of somebody who is living with HIV, every person has got the right, to have children. If that woman or the couple have got a desire to have a child, you understand. Or then those are the discussions that what would be the type of contraceptive that they would want to be, and when they don't want, to longer be on a contraceptive, how can they have a child? Now, coming to the contraceptives, we use what we call medical eligibility criteria. This is somebody who's living with HIV. Therefore, what are the best contraceptive methods to use on this individual? And let me re-emphasize that it's the reproductive health rights approach, meaning that the woman needs to make an informed decision in terms of what is the best contraceptive method for her. So what do we look at? We're looking at how old is the woman, when would she like to have a child again, or what is the reproductive lifespan, so that whatever contraceptive method that we use, how reversible in terms of, because like, for example, some of the injectables, you're looking at about up to 2 years before you can receive to primary fertility. So that is what we'll be looking at. The second thing that we're looking at, what medication is the individual taking. That will be, so now we're looking at drug interactions in terms of the antiretroviral drugs and the contraceptive method. So those will be the considerations. And also we would like to add, like the use of a condom, so that you would like that, besides preventing, you are preventing other sexually transmitted infections, and also you are also preventing, like the viral, like I would say resetting the viral load from recurrent infection. So as far as contraceptives, just to summarize what I've just said, we're looking at the age of the woman, the desire to have children, the spacing in between, reversibility of the contraceptive method, and the drug interaction between that contraceptive method and the antiretroviral drugs.
That's a lot to take in. Thank you. Andrew, I have to ask you, this leads to the next question. We now have a woman that's living with epilepsy who, let's say, is also living with HIV, all right? And she's now going to fall pregnant. So now we get into the space of just talking about the medication and how does a woman in that space, when she's living, we're talking about quality of life, of focus on health. How do we open that conversation? Maybe just your input, and I'd love to hear from Rue and Sibongile.
Yeah, see, the important thing to basically say right at the outset that both obviously HIV and epilepsy are treatable conditions, responding very well to chronic, albeit chronic obviously, but medication. So it's important to emphasize, although firstly the diagnosis of epilepsy must be made, but once a person is treated, there's a high likelihood that they are actually, with the medication, able to function fairly well, or even normally. So it's important that there's only a very small percentage of people living with epilepsy who have very poorly or difficult to control seizures. So it's a diagnosis that once it's given and correctly treated, it's not a bad thing. It's similar to HIV nowadays, where you basically follow the treatment plan and you can control the virus. So that is how we have to look at such a person, obviously. When it comes to using anti-epileptics in the context of an HIV positive person on antiretrovirals, that has certain determinants, because there are obviously medications that interact with each other, and we want to avoid as much as possible to create an imbalance between those medications.
Yeah.
The liver and the kidneys have to work on the metabolism of those drugs, and we must be careful that we choose the right combination. So there is certain medications that we do recommend as anti-epileptic drugs, as better choices that go together with antiretroviral medication, as opposed to somebody who is not on ARV. So that is being handled by the doctor, and we have very good and efficient drugs, and we have some drugs which we use obviously preferably for a HIV positive or person living with HIV who has got epilepsy, drugs which have minimal interactions with other medications. So basically that's the principle that we use there. When it comes to pregnancy and treating HIV and epilepsy, that treatment continues as is right through pregnancy. It's important to control the HIV and the seizures during pregnancy, and most of those, or pretty much those pregnancies can be highly successful and almost virtually normal. Need to be monitored appropriately, obviously, but there's no reason for such a woman not to have her reproductive dream or choice fulfilled of having children at all.
Yeah. That's
so
just,
that's good news, in fact, really.
yeah, it's a beautiful way of just contextualizing it, because I think once again we're having a conversation where there's so much fear. There's so much fear of, can we ask these questions? These are relevant questions to be asked. And sitting in a panel like this going, well, let's face it head on. Let's say, you know what, these are the tough questions to ask. We can say, can this be done? Of course it can be done. And we're hearing from a panel of experts that I'm so thoroughly enjoying. Rue, you are sitting there and you are quiet and you are come on, jump in here. Give us she's not quiet all the time. I know that.
On the topic of epilepsy and pregnancy, that's the side I can comment on, you know, and having a diagnosis quite late in my life before I've had children, you know, it was just a matter of opening the conversation. I was petrified of going on medication. I was so scared. I was like, what's it going to do to my fetus and this and this and this and this and this, going full steam ahead. But I brought my neuro on board. You know, I'd asked the relevant questions to my gynae. Do you know what I mean? There's no interaction for the particular medication that I'm on, you know, and there's nothing that would stop me from having a viable pregnancy. You know, it's also to a point where, you know, I think more people need to open the conversation. A lot of the time people don't know, you know, they're scared, but they're too fearful to ask the relevant questions. As a woman of childbearing age, it's important to be able to open the conversation. You know, what interactions are you going to have? And I assume it would be the same in the context of HIV. You need to ask, what are the drug interactions? And I think it's important that this panel is so important, because the whole point of it is to get people talking. Not only in the sense of stigma, but, you know, for someone living with epilepsy or HIV to start asking questions. That's the only way you're going to get answers, you know. So that's my comment.
One of the beautiful quotes by Nelson Mandela, and I never get this right, but he talks about education. And education is powerful. When you have knowledge, you have education, you can make decisions. And right now we've got access to, my son always reminds me, Mom, just Google it. And I think today we've got more access, with more people with cell phones in their hands than ever before. We've got more spaces, restaurants, environments with free Wi-Fi. So if you are coming from a space of, I need to know, and you're not being held back in fear by your community, by your loved ones, it's a case of stepping out and going, I can discuss this. And breaking the stigma and having conversations. It's just, I don't know. You were going to add something. I could see you as Andre was talking.
Yeah, you know, coming to the issue of education, it's very important, because sometimes people living with diseases, when you take an informed decision, like for instance, when I fell pregnant in 2007, I took an informed decision and I spoke to my doctor and asked to say, because I'm in ARVs and now I want to have a son, and I'm told that my son I want to have a child actually by the time, because I didn't know what gender it is. So I want to have a child.
You look very young though.
No, I'm not that young, I'm 46. So I wanted to have a child, and I didn't know what is it, because I will hear these stories from people to say you can't give birth, you can't do this and do this. And I went to the doctor and said, doctor, this is what I want. In my plan for life, I never wanted to have only one child. So I need 2 or 3 at least. And the doctor said, you are on ARVs and you can take your medication. What we need to do now, because at that time I was still taking efavirenz, stavudine and lamivudine, yes. So he said to me, efavirenz, we are not quite sure about it. We are still, studying it, and there's new information that it doesn't, like you can't get a child with disability if you are taking efavirenz. So I was like, okay, I'm prepared to wait. When can I come back to you so that you give me more information? And I was lucky because I had the doctor who was willing to listen and give me information. He said to me, no, I'm still going to find out, but after we come back. I went back to the doctor and said, no, we don't have to change your medication. You can continue with the medication. As long as you adhere to your treatment, chances of you having a child who's HIV negative are very high.
Okay.
And I fell pregnant. I had my son. He's 14 years old now. He's HIV negative. I had my daughter in 2011. She has Down syndrome, but she is HIV negative, and they are both healthy. So what I'm trying to say, information is very important.
Yeah.
And with my decision of having a child in 2008, there was still that stigma to say when you are HIV positive, other people, they know that you are HIV positive. I remember when I came back home after giving birth, having my son, everyone in my community wanted to see my child. Wow. And I knew that they want to see that is this child having an HIV or not. Of it was stupid of them because they can't tell by just looking at the child. But for me, it was another journey to say you need to know, you need to be educated, because I'm definitely sure that my son is not HIV positive. And even though I went for a test for him to be tested, to be sure, made sure that I give him nevirapine at that time until those days. But he was HIV negative, and other women started to say, if she can have a child who's HIV negative, then I can take that decision too. Because some of them, they will come to you and ask you, and you give them accurate information to say, go talk to your doctor, because as much as we have HIV, all of us, but we are not the same. So it's important to talk to your doctor.
100%. I think, I'm finding it fascinating because we're talking about 2 medical conditions that are invisible. And that is the ongoing discussion around epilepsy, is that it's an invisible disability. And one of the things is and Andre will, and it's just interesting. One of the things was, like, as a person with epilepsy, you don't listen. Okay, so can you understand that what petit mal or absent seizures are? Because I actually didn't hear part of your conversation. And it's that consistent conversation of somebody looking at your child, wanting to see what's wrong, but obviously you can't sense it. It's invisible, right? It's invisible. But again, you go back to people need knowledge. Exactly. People are ignorant, and you get treated differently. And it's actually having the courage to really have that and stand up. And what you've done is incredible. And I want to honor you, and I want to honor Rue, because discussing what openly like this is something I've become so deeply passionate about. And I'm standing on the top of the hilltops going, please talk about your differences, because the world needs people to be talking about our differences, celebrating with medical professionals alongside us, going, these are your facts, and this is what we need to be sharing. So I'm going to, that's enough of what I'm saying.
When Sibongile was saying, when she got pregnant, those years, it was like when you're HIV infected, you must underline the operative word, must not have a child. I used to work in an HIV research unit, and I remember one of the calls, our receptionist would, if you are at the office, she would put any public calls, through to you. And a concerned citizen was asking that, like, hi doc, why is it these women are allowed to have children? What is going to happen to all these children? Shouldn't there be a policy? Why are you not advocating for a policy that HIV-infected women must not have children? So with awareness and education, we should have more of that. We have come a long way. Because more people now are more understanding or accepting to that everybody has got a right to, to reproduce.
Absolutely.
So the more we have these discussions and having awareness, not only for the person who is living with the condition, we need to have more awareness to be inclusive of the household and the community at large.
Absolutely. And I think again we go back to fear, we go back to stigmatism, we're going back to people being treated differently because they're different. And something that came up for me as you were speaking, actually a few things, but I wanted to bring it back, is that we know HIV can be transmitted, all right? One of the things that we certainly I get asked, and I do speak about it, is epilepsy hereditary? And you know that's what I was going to come from. Because what we do know is that anybody sitting here could develop epilepsy at any time, at any point. Nobody is exempt from epilepsy. From head traumas to accidents to secondary infections to primary infections to having another neurological disorder that triggers epilepsy. We see it. So I suppose let's just ask you about that loaded question, because we don't have much. We've got a couple of minutes, and I want to open the floor to any thoughts that each of you would like to close with.
Make it quick. So firstly, it's not contagious.
No.
That's important. Yes, epilepsy is not contagious. It can affect all age groups, from baby, newborn, all the way through. The peaks, in fact, of epilepsy occur in the young childhood kind of years, and then in later age due to other conditions typically. So it's not contagious, and it's also not hereditary. Let's just put it that way. There are very few rare syndromes whereby epilepsy can occur on a familiar basis. But it's really, when we speak about epilepsy in general, it's not hereditary, so you don't give it to your child or to your offspring, and it's not contagious, and it's treatable. So that's it.
Thank you.
Nothing
Thank
else.
you. Nothing else. I'd like to just go around our speakers and just closing thoughts. We've got a couple of minutes, and post our, when we go off air, each of our panelists will have time to share thoughts that they have forgotten about, thought about, and wanted in personal space online. So, Rue, just a closing comment post this conversation session for us.
Well, I think my biggest take home is that, epilepsy and HIV are chronic illnesses and require treatment. I think more people, if you feel something's not right, take the initiative and get the necessary assistance. In my case, I didn't, and I went more than 20 years, battling this invisible disability. There is help, there's life after epilepsy, and I think that's where I'll leave it.
Thank you.
What's my take? There's a lot of them. I think my summary, take, is it's quite important to know about your illness at individual level. I like what you both said. You kept on saying that I engaged my neurologist, I engaged my doctor. And I'd like to appeal even to that individual who does not have a primary healthcare provider. There is primary healthcare providers at public health level. The most important thing is that be curious about your illness. Don't be scared to ask questions. I know sometimes we are scared to ask healthcare providers about what's wrong. Leave that healthcare facility knowing much more about your illness, and you are the one who's managing your illness even more than the healthcare provider.
Yeah, that's so true, because you live it. Keep a diary, keep notes, so that you can actually sit and go, last time I saw you, this and this and this has happened, and I need to know, because here's facts.
Yes, and no green tablets and yellow tablets. You know, the name, but like, this is what I'm taking, whether you're educated or not educated.
Yeah, absolutely. Last takeaway is just comments. This comments before I close us off.
You know, it will seem like we are singing the same song.
We can. We're shouting from the treetops.
Exactly, because you know, for me, my take home is that I feel I'm blessed to be part of this conversation, and I think it's a God decision for me to be here and learn about this. And just what happened last night and today I'm here, and having a daughter who was just recently diagnosed with epilepsy also. I think this is a space for me to learn more about epilepsy. My daughter just diagnosed March this year with epilepsy, and another different type of epilepsy. So in our communities, we don't know about these things. And you know, being an activist like I am, you must be sure, Sharlene, that it will be around the community. You'll be invited to come and speak to the community, because I always want to give information to community. Every chance I get, I use it. So I think epilepsy, we're not talking about it, and it's something that we really need to talk about it. And I believe now that a lot of people are living with epilepsy without them knowing.
Correct. Last closing thought.
Well, it was a wonderful, valuable discussion, Sharlene. Thanks for having me, being part of it. I think the main thing is really this empowerment issue and education issue, and it's basically also the person's responsibility to take charge of their own health. And if they do that, I mean, there is nothing stopping anybody or being stopped through epilepsy or HIV for that matter. So really, that's the appeal to people out there: take charge and take the initiative to be empowered. Right?
I just want to say to all our viewers and to our panelists, thank you so much for your time, for spending time with us. We have had the most amazing year in partnering with Sanofi in providing this platform of engagement, of information sharing. And I know, as National Director of Epilepsy South Africa, that I'm certainly looking forward to 2023 and the ongoing webinars and discussions. We have not closed out a number of the topics this year, and please, we know that we will be revisiting these conversations, as well as some really bright, beautiful new topics. So go onto our website. There's lots of information under our library. And thank you once again for joining us. Have a blessed Christmas. Be safe over this festive period, and take time out with your families and loved ones. Thank you so much.